Hello, and welcome to the MOASK Billing and Coding webinar. My name is Nicole East. I'm the Executive Director of MOASK. We appreciate you joining us today for this important information. So a few housekeeping items before we begin. Please keep your lines muted to avoid background noise. If you do have any questions, feel free to type them into the chat box or unmute your line. This webinar is being recorded and will be available tomorrow. We will also email the slides and any resources mentioned in a follow-up email. I am pleased to introduce our speaker, Lori Weber. She is the Part B Provider Education and Outreach Representative with Noridian. She will be discussing updates in oncology billing. So without further delay, I'll turn it over to Lori.
Well, thank you so much, Nicole, and for setting all this up. Can you hear me okay?
Yes.
Excellent. Well, I want to welcome all of you as well on this medical oncology coverage, and we'll look into some other hot topics as well. So hopefully you can see the screen. And I welcome, we also have Dr. Arthur Lurvey with us, one of our medical directors, and he will be here to answer any clinical questions because I am not a clinician and I don't play one on TV. So with that, we'll get started. With my slides one minute. There we go. This is our disclaimer we have on all of our webinars, all of our outreach, just letting you know this is an as-is product and correct as of this publication. The information could change at any time, as you know, with Medicare. And the best way to keep up with Medicare, in my opinion, is to have the Noridian Medicare website for JEB and the CMS website bookmarked, and also sign up for our weekly emails or have somebody in your office taking care of that. Our agenda today is pretty long, but yet condensed. We have 60 minutes or so, and it's going to include an overview of oncology services, although I did take out a lot of slides introducing oncology because I know most of you are in this world, so you didn't need that information. But I am including documenting medical necessity, discussing some guidelines for billing drugs and biologicals and their administration, what happens with evaluation and management codes like an E&M office visit, and then we'll go over some common errors, some hot topics, and resources.
Lori, people are saying that it sounds muffled. Is there any way you can get closer to the microphone or make it just a little bit louder?
Yes, let me try that. Or maybe is this better? Is this better?
It sounds good to me. Kelly, how does that sound to you?
It's still a little difficult to understand, better than it was a few minutes ago.
It just sounds like she's on a speaker, like a webcam speaker, rather than like a headset or something.
You're right, because I am.
Yeah, that's what it sounds like.
Okay. Let me see. And I so apologize. I'm able to do this on a lot of my webinars to be able to just use the speaker, but it must be something. I don't have a headset that isn't tangled up somewhere. So is this any better?
I hear you better. How about anybody else?
I mean, I don't think it's going to end anything, right? You're going to be pretty much reading slides, so it should be clear if we can follow along with you. No problem.
Okay. Well, I do want you to have the other information, and I'm so sorry about that.
It's a lot better now. It is definitely better.
Okay, good, because I did move closer to the computer, so thank you. So let's look at some of those services and oncology coverage explanations. So we all know that the drug benefit under the CMS Internet Only Manual outlines specifics when a drug or biological is covered. If the following requirements are met, it must meet the definition of drugs or biologicals. They are the type that are not usually self-administered. The practitioner must meet all the state requirements for coverage of items. Also included with that is incident to a physician services. They must be reasonable and necessary for the diagnosis and treatment of the illness or injury administered, and that they're not excluded. For example, you would have those non-covered immunizations, and that they have to be, that they've not been determined by the FDA to be less effective. So if there's some kind of indication or supported use in the CMS approved compendium. And so we added the IOM link under this in the resource slides. Now, the key to any service is medical necessity, right? It's essential for providers to clearly document the medical necessity for all services. And if there is no documented evidence, for example, any kind of objective measurements of ongoing significant benefit, then the documentation must provide other clear evidence of treatment medical necessity. And it must also clearly indicate the complexity of the skills required by the treating provider or clinician. And as you know, most chemotherapy or anti-neoplastic drugs are listed in the HCPCS Level 2 book, and they begin with that letter J or Q. So refer to the HCPCS table of contents to locate the specific code for the drug to be used. Now, when a physician administers chemotherapy in the office pays for the cost of obtaining the drug and then bills Medicare for the cost of that drug. And that includes administration and any other covered services provided at that visit. We have providers that can bill Medicare Part B only when such drugs are purchased by the physician and then also administered in their office. So if the drugs are purchased elsewhere, the physician can bill just the cost of the administration and other covered services that were provided at that visit. In order to meet all the general requirements for coverage under the Incident to provision, FDA-approved drug or biological must be furnished by that physician and administered by them or their auxiliary personnel that are employed or under that personal supervision. Pharmacies cannot bill Medicare B for drugs furnished to a physician for administration. The usage of incident to is not like some of us are used to hearing, where a non-physician practitioner performs a service incident to a physician. In this case, when a drug reflects an expense to the physician, then both the drug and the administration can be billed by either that NPP or advanced practitioner, or they can be the supervising physician if they're in the office, to auxiliary personnel, as long as they have the state scope of license. And so administration of the drug is only payable if the drug would have been covered had the physician purchased it. And here's the reference links to the CMS IOM manuals. Then we get asked about donated drugs or free of charge. Maybe they're provided free of charge to the patient. In those cases, to avoid administration code denial, a drug code should be present on the claim. And so we're going to need to know what drug was administered to determine if the correct administration code was billed. And you'll need to include the following items on the claim. So you have item 19, where you have the phrase, this is that narrative box where you're going to have drug donated. or if you're billing a not otherwise classified or NOC drug, include a drug description and the total amount administered. In 24D, you'll have that J code. In 28, you'll need to enter a billed amount of a penny because the system rejects if you bill 0, even though we know it's 0. So that's something that came from our adjudicators. And the payment allowance limit for Part B is still based on the average sales price, the ASP plus 6%. And those allowances will be based on the lower of the submitted charge or that ASP file price. Here's the ASP and NOC pricing files in this link, or you can get to this CMS page by going to our Noridian fee schedules tab that you can click in and takes you out there. Now, the allowed amounts are updated quarterly, January, April, July, and October, but that doesn't mean every drug is going to be. And then here's some unlisted and NOC HCPCS codes that are only used when a more specific code is not available. So you've got the 3490 for unlisted drugs, 3590 for unlisted biologics, and then the 9999 for unclassified anti-neoplastic. So when you're billing these, we want to have you enter as concise of a description of the drug as you can, and that name, dosage, administration route, if there's more than one route of administration that could be addressed. And then in item 19 or the electronic equivalent, if the required information is not submitted, any of our unlisted procedures or services will be denied as unprocessable, so the claim will be rejected. We don't want that to happen. So we don't correct the coding of an unlisted procedure, especially when a valid code is available, excuse me. So just make sure you've checked that there is not a valid code before you bill an unlisted code. And you don't need to attach any invoices because if it's needed, we will request it. So make sure you keep it, but you certainly don't need to send it with the claim. Now we're going to get into the NDC number that I get asked about for multiple vials with a separate NDC or National Drug Code number. As long as it's for the same medication provided to the same patient on the same day, you only have to bill one line without any modifier. Reflect the NDC numbers in documentation. So you don't have to do it on the claim, just do it in the documentation. And that's in case any post-pay reviewers request it, like our medical review department or the recovery audit contractors, the cert contractors, etc. Our medical review department told us that even with multiple NDCs, they don't review that when the claim comes in. So just bill it all on one line. And of course, then reflecting your documentation. We used to tell people to use a modifier 76 and fill on a couple lines, but that's no longer necessary. So let's talk briefly about unlabeled use for anti-cancer drugs. If the use of the drug is not included on the FDA label, it still might be covered, even though I said earlier it must be an FDA approved. If Noridian determines it to be medically necessary and takes into consideration with the major drug compendium or documentation of an authoritative medical literature, and then it has accepted standards of medical practice. So you may be requesting that if you have not had it approved. So the IOM reference at the end in the resource section will talk about all of that and where to address that. Now, I think I have 7 slides or so discussing drug wastage. So when a physician must discard the remainder of a single-use vial or package after administering a dose, CMS does allow payment for the amount discarded up to the vial or package label units. And this has been around for a couple of years, so you probably know all this, but I thought I would just reiterate in these next few slides to make sure that everybody understands. It does not include remainders for multi-use vials or when dilute compounds are used, to reduce viscosity, etc. Or it does not include reporting overfill wastage. So remember, another patient cannot use any waste from a single dose vial. And I think this is also for all insurance. I don't think it's just a Medicare thing. Your documentation should include the actual dose administered in addition to the exact amount wasted of the total amount on the labeled vial. And we're going to have some examples coming up. The two modifiers are not used for multi-use vials, as I just said, or when the actual drug dose administered was less than the billing unit. And remember, those modifiers don't apply to vaccinations or that overfill wastage, as I just said. Or even in the rural health clinic or FQHC, Federal Qualified Health Clinic, or health center setting. So due to rate inclusion when packaged for the OPS program, which I'm only speaking to Part B and OPS is Part A, I still want to talk about it for a quick second. When it's packaged for the OPS or an ambulatory surgical center, an ASC, or even hospital inpatient admission, it's billed under the IPPS, the Inpatient Prospective Payment System, and would not be eligible. Now here's CMS's position from the Federal Register, and in the Code of Federal Regulations, or CFR, originally we thought that JWJZ modifier would treat diagnostic and therapeutic radiopharmaceuticals in the same manner, but they are excluded for this CFR note under bullet 2. A drug that's therapeutic, anyway, I don't have to read it to you, but you see it there. Make sure that you check out this last link of HCPCS codes. It's about 14 pages, I think, and was updated in November of 24. So check it out because it'll tell you all the codes that are involved, because we get that question too, which J code. So it does have to be still that single use file, but that's going to help you a lot to have that spreadsheet, like maybe saved on your desktop if you do a lot of billing in that world. So again, I may sound like a broken record, but wanted to make sure everybody understands CMS requirements that providers must bill Medicare for their drug wastage if the requirements are met. And it requires the uniform use of JW modifier for claims with discarded Part B single-use vials. That's for drugs, biologicals, and even skin substitutes, which we are not discussing today. The units billed would correspond with that smallest file available, and if the dosage is not in a multiple of the number provided. So make sure when you're billing, you round up to the nearest whole number, and that'll make more sense in our example. If less than one unit is administered, then JW is not appropriate. And I must have liked this link as I added it again here and retitled it. So, but it is the same as the last slide link. And also note that this is not an all-inclusive list, this 80+ codes. So, how do we bill for drug wastage? Well, the first line has the JW modifier, has no modifier, I'm so sorry. Or if nothing was discarded, append the JZ, which we have an example coming up. Then the second line would be just the wastage piece with JW appended. The claim example here is for Avastin, and as many of you know, it comes in 100 milligram vials or 400 milligram single-use vials. So if the dose administered was 305 milligrams, you could either use 4 of the 100 milligram vials or one of the 400 milligram vials. You'll have the same amount of waste either way. So let's say it was used 305 milligrams that we talked about earlier. That would equate 31 units because they're 10 milligrams each. And we're also rounding up the last 5 milligrams. So that's why you see 31 or up to 310. And then 9 units are wasted. So bill the J9035 for 31 units, and the second claim line is J9035 with the JW telling us for 9 units was the amount wasted. And then when there's no wastage, I think it was back in July of 23, Medicare required the JZ modifier was on claims for those single dose drug containers where there are no discarded amounts and just append the JZ modifier to your drug code. And that'll indicate no waste. So back to our Avastin example, we had a 300 milligram dose. But let's say you're just using 3 of those 100 milligram vials because that's all that was needed. So there was no waste. So you just fill that with the number of units 30. Now, not on the slide, but an important note is that a single dose vial cannot be used on multiple patients. And that's not just a Medicare rule. If either of the modifiers are missing from the claims for a single dose drug container, they're returned as unprocessable, those claims. So you don't want to have a rejected claim and hold up your accounts receivable. So for each incoming initial claim line without a JW modifier, there must be a paired second claim line with that JW. If the JZ modifier is used, then there's no lines with JW, obviously. Noridian has a policy billing and coding article that's available with those directions. And also CMS has their FAQ at these links right here. Now I'm changing subjects here, going into the ESA, the agents that stimulate a patient's bone marrow to form new red blood cells. I'm sure you all know they are used to treating anemia by elevating or maintaining the red blood cells level, and that's demonstrated by the hematocrit or hemoglobin levels. Therefore, decreasing anemia and the need for transfusion. So this last bullet shows a couple of ESA drugs like Epigen and Aranesp for that anemia. And Nicole, I'm checking in. How does it sound?
On my end, it's good.
And people can put in chat, you know, if it's really terrible. So, okay, moving on. We've got, remember that submitting your claim with an ICD-10 diagnosis found in the National Coverage Determination or NCD, I have a link on the next slide, does not necessarily assure coverage of the specific service, but will determine appropriate reimbursement. So just make sure that your documentation meets the criteria, includes the patient's weight in pounds or kilograms, and per that analog units are administered. If you're exceeding the doses, medical administration justification is needed in that documentation. And these are the HCPCS codes, but we used to have an LCD policy that was retired due to the material being addressed by the NCD that's enlisted here under 110.21. The ESA treatment's not reasonable and necessary for patients with certain clinical conditions, which specifically narrows the use of ESAs in cancer and neoplastic conditions. So billing for the ESA with the appropriate HCPCS codes and modifiers are really important. So that ESA billing for non-ESRD will include J0881, and then for that Aranest and the J0885 for the Epiton Alpha. The takeaway is both that these HCPCS are for ESRD and non-ESRD use only. And for the non-ESRD, they need one of these modifiers appended. So it can be EA for treatment of chemo-induced anemia, EB for radio-induced anemia, and EC for non-chemo or radio-induced anemia. So CPT 96372 is the administration code where you specify the, the drug separately, and it will cover the administration with the above J codes. Now, providers are also required to report the recent hemoglobin or hematocrit level on the claims for the anti-anemia drugs. Now, when I say on the claim, I mean in the narrative, in item 19, in that block or box. There's nothing on the claim line, but only in the narrative. So with electronic claims, which most everyone is billing these days, you report those readings in the Loop 2400 MEA segment. Apparently our adjudicators see sometimes they see the error under segment NM, like New Mexico 107. So we don't want you to use that. And I did not put that on this slide, but you may want to write it down for your clearinghouses or your, practice management systems, that they don't want to build that into segment NM 107. They want it to be under the segment MEA. So the readings breakdown is MEA 01 or for TR for test result. MEA 02 is for the hemoglobin for R1, and R2 is hematocrit. Then you have MEA 03 for the 3-digit plus a decimal point for the numeric test. Apologies. For the numeric test result, or what they call the NN.N format. So it's really 4 digits altogether, but it's 3 letters and a decimal. So 2 letters, decimal letter. And those examples might be a 2400 MEA with the test numbers of TR, R2, 27.0 for the hematocrit, and then of course the other one has TR-R1, 09.0 for hemoglobin. And remember, you'll get a copy of this in a PDF form, so you don't have to memorize all these slides if you don't know this piece. So, going on to slide 25, we're on hemoglobin and hematocrit test result numbers. Again, they should be that 4-byte value that I just talked about, with 2 numbers, decimal point, and another number, and follow that format. It's very important to note that here, that the decimal point must be submitted as part of that submitted value. If the test result is less than 3 numbers, then you want to make sure to enter zeros in front or at the end to give you the 3 to 4 digits there, as demonstrated in this example. If the 2-digit number is being reported as 45, then you want to put 4.5. If 2-digit whole number is being reported, such as 28, then 28.0 cent. And then if a 2-digit number is being reported as a 12.5, then 12.5 show. Now I've got 3 slides on that. I think I'm pronouncing it correctly. The chimeric antigen receptor or CAR-T cell therapy. That is a type of immunotherapy that uses genetically modified T cells to attack the cancer cells. And you probably know that already. So we cover the therapy for certain types of blood cancers. However, there are specific criteria that need to be met, including a diagnosis of a qualifying condition and a receipt of the treatment from a facility who's enrolled in the FDA risk evaluation and mitigation strategies, or what we call REMS. There's just certain approved facilities for this. So you can read more about this in the policy link provided for 110.24. So we have covered this for a little while. I think we implemented in 23, and it does allow in place of service 11 for office and 49 for an independent clinic, as long as they are REMS approved facilities. The first is that for most of the approved party cell related HCPCS codes, they cannot be processed in the Medicare system because the field length for the dollar amount is only 7 digits, and CAR-T needs to be billed as 1 unit because they were like way long. I want to say 8 digits. So in order to bill claims correctly in the Part B setting, you'll need to split the billed amount of the HCPCS codes onto multiple lines. And CMS created a new modifier to append LU, and I think we have that on the next slide, that indicates fraction units, and we'll review that process coming up. So secondly, when the dose exceeds the code descriptor for CAR-T cell products, use the unlisted codes, J3490, 590, or 999 for that exceeded dosage. You can bill a total of 1 unit of perhaps there's a Q code, in this example, 2041, plus 1 unit of the J code, include that cell product name and the exceeded dosage in item 19 or electronic equivalent. These are very expensive drugs. So you want to make sure that you can bill it all and divide up those HCPCS codes by 10 and bill in 0.0 or 0.1 unit fraction. You can have a total of up to 10 claims with those fractional units to reach total Medicare allowed payment amount. And if the Medicare allowed payment for the CAR-T cell HCPCS code is under $500,000, then you could submit these 5 separate example claims for 0.2 units on each claim. And we pay up to 1.0 units, and they should iterate. That's not to confuse with 0.1 units. So as you can see, 0.2, 0.2, 0.2, 0.2 doesn't add up to 1 yet. So that's why this is okay. And other modifiers that are listed in this third bullet, of course, are the LU for that fractional payment. You have a 70, you might have a 76. It looks like in our examples we have it. This is a repeat procedure by the same physician. And that is needed so that your claim doesn't deny as a duplicate. And then you have that modifier KX. And what that is, KX is different for different codes. We use it also in outpatient physical therapy, but in this case, its requirements specified in medical policy have been met, and they're part of the FDA REM facility, so that you don't have to send in your certificate or anything or prove that you're a REM facility. You're doing that with the KX. And then if we need to, in an audit, if we need to look at it, then we'll ask for it. So here's the example of how that would look for $445,000. First claim would only need two modifiers, LU and KX, because it's the first one, right? There's no repeat. But the second through the fifth claims need three modifiers, the LU, the KX, and 76 for the 0.2 units with each charge. And that should sum up to $445,000 for all five claims. So as you see here, we have a variance of $88,999 in odd pennies. So for more information, please check out the CMS revised MM 12928 that I've provided the link. Okay, so now let's look at the codes and administration of drugs and biologics. And hopefully this will help too, because this can be so confusing. So administration falls under three categories within the CPT. You've got hydration, therapeutic, prophylactic, and diagnostic injections and infusions that may exclude chemotherapy. And then thirdly, you've got chemotherapy administration based on the medication and not diagnosis codes. For instance, a patient comes in with an active cancer diagnosis, but is receiving treatment with nausea and vomiting medication. The administration of the drug would be therapeutic since it's based on the medication. On the other hand, a patient with multiple sclerosis or rheumatoid arthritis may be receiving treatment with methotrexate, a chemo medication. So the drug administration would be chemotherapy. So you just have to look at where they're coming from and where they're, what category they're under. And Part A also has a great chemotherapy presentation too. When Medical Review or MR has their prepay reviews, they're looking for codes within a group or family that they're reviewing. So here on the left, we have the IV infusions, which you know are fluids and they're drugs over a period of time for diagnostic and therapeutic purposes. They're time-based codes and they need to be at least 16 minutes or greater for non-hydration codes and at least 31 minutes to qualify for hydration infusion. An intravenous or intra-arterial push, IV, is defined as an injection in which the healthcare professional continuously presents the administration of the substance or drug and observes the patient. And an infusion is usually 15 minutes or less. Now, for the injection, of course, that's the dosage in one shot, may be administered by various routes, including subcutaneous, intramuscular, intra-arterial. Now, on the right side of the slide, we have the initial. Why is the patient there? And what's the primary service? The sequential, also known as the secondary. And these sequential codes are administered immediately after the primary substance. And then you have concurrent, multiple drugs or substances that are infused simultaneously through the same line. Now, they could even be mixed in one bag, but to be considered one infusion and not a concurrent infusion. So maybe I should repeat that. Multiple substances that are mixed in one bag are considered one infusion, not a concurrent infusion. And then remember that when you're billing for chemotherapeutic services in Part B, we use a systematic approach. Why was the patient here in the office? What was provided? How did you provide it? How long did it take? Instead of the code hierarchy like facilities use. So if you're here today from a facility, this is going to look a little different. Now, the hydration codes are used to report a hydration IV infusion, which consists of prepackaged fluid and or electrolytes. You have your normal saline, that sort of thing. But they're not used to report infusion of drugs or other substances. So you have your CPT 96360 for the IV infusion. For the hydration, this is the initial one, greater than 30 minutes up to 1 hour. And then you have your add-on, 96361, for the secondary hydration over 31 minutes, even though it's called an additional hour. Hydration less than 30 minutes is not a billable procedure to Medicare. Hydration that's integral to the performance of a surgical procedure or transfusion, or to establish an initial or underlying IV flow for a diagnostic or therapeutic infusion, is not separately billable. So a physician order for hydration is required that services are reasonable and necessary. And the coding shown on this slide is for the hydration performed and billed as the only service rendered on a given day, depending on time. And that's because we have the initial hydration code on it. Time-based codes must be documented with start and stop times. Excuse me. The hydration administration medical necessity documentation should be supported in the evaluation performed by the provider, and that's typically going to be on the same day, and the clinical assessment of the patient. Now, assessment documentation should describe the symptoms, warranting hydration, such as those associated with dehydration, any inability to ingest fluids, abnormal fluid losses, vital signs, and abnormal labs. As I said earlier, nausea by itself does not support necessity of fluid repletion from fluid depletion. Now, next up are the non-chemo administration codes of therapeutic, prophylactic, and diagnostic. You have your 96365, where you need to specify the substance or drug. This is initial, greater than 30 minutes, up to 1 hour. And then your 3 add-on codes, 96366 for the sequential infusion, 367 is for an additional sequential infusion of a new drug, and 368 is concurrent infusion, in which a new substance or drug is infused at the same time as another drug, and only once per date of service. I don't think I have that on here. Yes, I do. It's the last row. Only once per date of service. And then here's the non-chemotherapy push codes and injection CPTs with the add-on codes. So I put a little plus by those so you can tell at a quick glance which are add-on codes. And then we have CPTs 96401 through 96549, and even HCPCS G0498 listed here. They describe administration of chemotherapy and other highly complex drug or biologic agents. And we'll look at the portable pump code at the end of this section. And more chemo infusion and IV push codes. You have your 96409 for chemo administration, the initial substance, 15 minutes. And then your add-on, 96411 for each additional 15 minutes, 96413 up to 1 hour. And then if it's over an hour and a half, you can assign a 96415 add-on code as well. And then the 96417 is that additional sequential infusion of a different substance or drug up to the 1 hour and 16 minutes. And then some billing tips on multiple infusions of different substances or drugs. Assign only one initial service code if the medications are provided with the same IV site. The initial code best describes the key or primary reason for the encounter and should always be reported, and that's irrespective of the order in which the infusions or injections occurred. For example, if a patient receives an IV push before an initial 1-hour infusion, the IV push is still reported as a secondary service. And if the specific protocol requires that 2 separate IV sites need to be used, then report 2 different initial codes. And of course, like with everything, documentation is so key here to designate which sites are being used, which drugs are going into each site, and for how long. And if provided during a separate encounter on the same day by the same physician, utilize modifier 59. We used to say it was modifier 76, but our adjudicators are telling us now we want modifier 59. So if you have, here in the second bullet, if you have any overlapping administration times, if that injection or infusion is of a subsequent or concurrent nature, even if it's the first such service within that group of services, then you should report the sequential or concurrent code. There is no code for concurrent administration of chemo drugs. So utilize those sequential codes for overlapping administration times. And Medicare may pay for the infusion of saline, anti-nausea, or other non-chemo drugs when they're administered on the same day as chemo infusion when provided sequentially, rather than at the same time. And the following are all included in the infusion or injection administrations and should not be billed separately, and therefore they're bundled into the payment for chemotherapy administration. You've got your IV start, your local anesthesia, your subcutaneous catheter, port or indwelling IV access. At the conclusion of infusion, the flush. You have all the standard tubing, syringes, and supplies, and even the saline used in mixing chemo drugs. And chemotherapy agent prep or preparation. These services should all still be documented if performed, even though they're not paid separately. And then we need to advise physicians that you can bill the CPT 99211, that established patient when you have a special visit made to the physician's office for the sole purpose of line maintenance, that it can include line irrigation and inspection of the skin site. So you can even have your nurse do that. And that's why you don't have to be in the office. 99211 can let your nurse take care of that. So, but I should say, however, no other drug administration services can be performed that day. If you do need to declot a catheter report, you want to bill CPT 36593. And the documentation is always, you need the patient's name, date of birth, and date of service, preferably on every page. The physician must clearly document his or her intent for the drugs administered, dosage, frequency, and the duration of the chemotherapy treatment, with the medical necessity of the services supported. In order to determine the appropriate administration codes, the start and stop times must be documented in the patient's medical record at the time that the services are rendered. And you're certainly welcome to put the total time as well, but they really like to see the start and stop times with chemotherapy documentation. The medical record must contain a physician order clearly denoting the services to be rendered. Without this information, our services may be denied upon Medicare claim review. And I don't want your, I don't want the monies to be recouped. In addition, Medicare requires that all records contain a valid handwritten or electronic signature by the author of the records. Without this authentication, as you know, the records will not be considered during a medical review. Ensure that staff documentation matches the codes indicated on each claim form and that those codes are supported. It's very important that the staff person administering, if it's not the physician, must also sign the medical record and date and timestamp along with their credentials. So if it's an RN, an MA, etc. Also include the supervising physician's name and credentials in the record as well. Now, in a case, this is our last slide on these infusions. In the case that a patient is sent home for a portion of the chemotherapy infusion, if they're using an external portable pump, you would bill for the drug or biological chemo administration with the external infusion pump. Because prolonged drug and biological infusions started incident to a physician's service, using an external pump should be treated as an incident to service. And it can't be billed on the supplier claims to the DME or Durable Medical Equipment Acts, Medicare Administrative Contractors. What we do is we pay for the drugs and biologicals that are usually not self-administered and are furnished incident to physician services. As long as they're rendered to patients while in the physician's office, the physician or hospital must incur a cost for that drug or biological that we talked about in the very beginning. Now, in some situations, a hospital outpatient department or a physician office may have the patient return at a purchase after purchasing a drug for a medically reasonable and necessary prolonged drug infusion. They can begin the drug infusion in the care setting using an external pump. They can send the patient home for a portion of the infusion and have the end of the infusion period. So the G0498 that you see here must only be billed for the use of the external pump where the chemo infusion was initiated in the office or that other outpatient setting using those pump and supplies with continuation of the infusion in the community setting. G0498 may be used whether the pump is an item of DME provided by the office or an equivalent functioning disposable. This code is not to be billed to DME, as I just said, and billing this code once also includes the follow-up office visit at the conclusion of the infusion and when the pump and infusion is discontinued. G0498 may be applicable for the prolonged infusions of those drugs. So additional information is available in the Medicare Learning Network Matters MLN Special Edition article 1609. This is quite old, this SE 1609, but it is still has a lot of great information, and you just click into that link. Now we have a few slides, and I'm just going to go briefly because EMM can take 3 hours to talk about, as you all may know. We have so many, and I'll just go over some of the current EMM guidelines but I want to refer you to register for the March 4th EMM webinar that'll go into more detail. If you're involved with critical care, there's also going to be a webinar on March 6th. And go out and listen to any of our webinars on demand or even tutorials for further information. We've got a lot of great information. I'll have those links at the end and resources. So it's also important to note that physician or other qualified healthcare professionals with their work related to hydration, injection, and infusion services will predominantly involve affirmation of that treatment plan and direct supervision of their staff. And with these E&M code selections, they're based on either the time spent performing the service on the day of the visit or the level of medical decision-making, or MDM. And that's going to include establishing diagnoses, assessing condition status, and or selecting management options. Medical decision-making in the office and other outpatient services is defined by 3 components: the number and complexity of the problem that are addressed during the encounter, the amount and or complexity of data to be reviewed and analyzed. This data does include medical records, tests, and or other information that must be obtained, ordered, reviewed, and analyzed for the encounter. And then it does include the risk of complications, morbidity and or mortality of the patient, management decisions made at the visit, and associated with the patient's problem. So when time is used for reporting E&M service codes, the time defined in the CPT is used for selecting appropriate level of services. For 2024, all codes now must have a minimum time that be met in order to bill. So I think you all know those. There is some telehealth with that face-to-face or non-face-to-face time, and this is all the information that needs to be there. Now, I'm kind of concerned, how strict, Nicole, are you guys on your time? Because I see we only have 3 minutes left and I have 20 slides.
We can go 10 or 12 more minutes.
Okay, I really apologize, everyone. There was so much I wanted to present, and yeah, thank you. So here's that 99211, a level 1 E&M code, basically a nurse's visit. Because a physician or healthcare professional is not required to be present, cannot be paid if it's billed with a drug administration, like we talked about earlier, such as that chemotherapy infusion. So the drug and chemo administration 96360 through 375 that we talked about in the last section have all been valued to include the work and practice expenses of CPT 99211. So you don't have to feel that you're getting cheated by using those administration codes. So that is why that code is usually not separately reportable. And it's not allowed for patient phone calls or the blood draws, or even when infusion codes are submitted separately for the medication administration. So you have to make a decision, do I use that or do I use the administration? If you get, well, I would just choose the administration. But anyway, it may be necessary to indicate on the day of treatment the patient's condition and what's needed. Of course, we need to have work related to the hydration, injection, or infusion that would involve the treatment plan, supervision of staff, and just supporting the level of service. And sometimes there may be a 25 that needs to be appended to the E&M code. But boy, make sure that your documentation supports that, because an E&M may not be necessary. And you would want to make sure to document that. And then we have a couple of add-on codes. I thought they've been hot topics for us in the past, or for the past year or so, is that G2212 for prolonged E&M services. They exceed that maximum time to the highest level visit. So they're only, G2212 is only appended with 99205 and 99215. And you have to have at least 15 minutes extra on that date. So just make sure that you're aware of that. So we gave you a little example here, 69 to 83 minutes, what it might look like. Now, another one in the second bullet is the complexity visit add-on, code of G2211. So this one can be billed with any E&M, and even if the E&M has modifier 25 appended. Before, they were not allowing that. So you might want to see more information on MM 13705 for a list of preventive services that it can also be added to. So this is all about ongoing care for a patient with a single really serious or complex condition. And also in the last link is MM13473 that just came out in 25 that even explains more. So here's the documentation. I don't have to tell you that. And then some common errors I want to show you real quick that has to do with place of service. It's really key. It must differ from, facility outpatient departments and non-facilities. And we have a special page dedicated to home infusion therapy as well, right? Here under JEB. So you can also find information under browse by topic, drugs and bios under home infusion on it. An advanced beneficiary notice. We have a full presentation on this, but if you're expecting a denial and it's not an item that's never covered or statutorily excluded, you will need an ABM required prior to that drug administration if it's not going to be covered. Include the drug name, expected cost for the patient, explain the total dollars. I think most of you know what an ABN is, and you have to use the ABN form that's dated 1/31/2026, or it's considered invalid in an audit. That in effect is 23, and then here's the links. And then the formulation, a common error we see in an instance with the oral antiemetic drug Zofran, where the Q0162 is ordered, but the IV formulation of Zofran J2405 was billed and documented. So the reverse is common as well. So make sure that you're billing the correct codes and the type of administration needs to be consistent with that drug, et cetera, et cetera. And some of the medical review findings here, this is on pretty much all of them. It doesn't just have to do with oncology, but insufficient documentation, signatures, and the documentation sent was for the wrong date of service or wrong provider. It was illegible. Something was going on. And then some hot topics. Telehealth is on the hot topics list. We know that. I'm not going to go into this, but this slide will really explain everything we have. We have nothing new past March 31st, but we'll let you know as soon as we know. Beneficiary eligibility, if you use our portal, this is really important. It will be removed from the IVR systems. I believe they said as of March 4th or something, but I just put March at that time. We didn't have it. So just make sure that you're signed up for the portal because it's really going to help you. We do want to remind everybody to share their documentation. It doesn't defy HIPAA or anything for you to share those records. It is, especially for our labs and diagnostic facilities and DME suppliers. We need the physician community to share their referrals and orders, and shouldn't cost much just to fax it over. So you can read more how CMS wants this to be complied with in these links as well. And duplicate claims, we're asking not to send in another claim until you received your remittance, that it's either denied, rejected, or timed out for something. So that gives you all the information on what our timeline is. And then the IOM resources that for some of the information we talked about today. And then Noridian, we have browse by pages. We have an oncology and hematology page. Probably needs a little updating, but it is out there. We also have incident 2 and unlisted codes. The LCA articles. Now this is no longer called LCAs. It's now called billing and coding articles. So I will make sure to get that changed at some point. But for our training today, you know what I mean. And these were some other ones that I thought you might find interesting. and we have retired the Complex Drug Administration. However, remember that when an LCD or a billing and coding article is retired, the info may still be good. So, you can always keep it. And then listening to our tutorial recordings if you have new staff, new billers, new providers. And with that, I want to thank you all for joining me so much. And I am going to ask that it would mean a lot to me if you would take a few moments to complete this survey by scanning the QR code with your phone. Our management and CMS wants to see how we're doing, and it asks your overall satisfaction using a 5-point scale, with 5 being extremely satisfied, and I cross fingers, and 1 being extremely dissatisfied. So with that, Nicole, how are we doing? And thank you all very much.
Lori, can you hear me?
Yes.
This is Dr. Lurvy, and in a formal meeting that I had some months ago with Nicole and all of her colleagues at MOAS, a question came up that I wasn't sure of, and maybe you would be, and that is many patients who are on chemotherapy or a combination of chemotherapy and biologic drugs have a port put into one of their arms, which is a continuous area where you can put in and take out needles and give medicines. When they come in subsequently, there's almost always a flushing of the port, and then in a separate area or the other arm or the other something or other, there's an IV given. It may be for contrast, it may be for a drug or something, but they don't necessarily give it in a port. How would you code that, since there are 2 IVs, or there are at least 1 IV running and a flushing of a port in a separate location?
I think the flushing is already what they consider included, and I thought I had a slide on that, but maybe I'll stop sharing here for a minute so I can look through the slide deck, because that's an excellent question.
Nicole, had you found the answer? Because I was looking for it and didn't have it, couldn't find it. That's why I thought at the end of the meeting I would ask it again.
I will have to go back and check my records. I'm not sure.
Okay.
I can tell you what we do here. We only bill the port flushes if that's the service that they came in for alone. So if they had any labs or a doctor's visit or anything else like that, it does not get paid. In fact, it may, if it does get paid, it then trumps some of the higher billed items. And so we do not bill those on the same data service with any other type of visit.
Well, typically these patients, and I visited 1 or 2 getting oncology services in the outpatient part of the hospital because they were friends of mine. And I realized that they were having like 2 IVs. One was they were cleaning and flushing the port, and the other, and the doctor is doing this, or he's talking to the patient, they're getting an image or something, or giving a medicine in a separate vein in a separate place. So it's like 2 IVs. And I don't myself, not sure if you use a 59 or another special code. That's why I was asking.
Yeah, if we can do that ourselves, that would be good to know as well.
Yeah, I'll research that. And Dr. Lurvy, maybe you could email that to me. But I also want to make sure there are any other questions from the attendees today.
I don't see any in the chat, but if anybody thinks of any questions or needs more information, feel free to email me at neast@moas.org. And if I can't answer your question, I will certainly reach out to Lori or Dr. Lurvy to get the answer and provide it to you.
Thank you.
Oh, Nicole, thank you. And I see we only had 11 today out of 110.
No, we had 17.
Oh, good. Okay.
I think a lot of people will register and wait for the recording.
Okay,
I'll go ahead and put my email in the chat, but again, that was neast@moask.org. And sorry for keeping you all over a little bit today, but we thank you for attending, and this concludes our webinar. Thank you so much.
well, and thank you guys. I appreciate your time. Thank you. Bye-bye.
Thank you.
Great job, Lori.
Oh, thank you. It's a lot.